Welcome to this special podcast series from the National Institute for Health and Care Research about the future of research. You'll be hearing from 5 clinicians who are the current Thames Valley and South Midlands Clinical Research Network Fellows. We will be discussing the big research challenges facing healthcare. I'm Dr Sanjay Ramakrishnan. I'm a research fellow in Respiratory Medicine at the University of Oxford, and over 4 episodes I'll be asking my colleagues the tough questions. Are we getting trial participants who are representative of our diverse population? Is our research workforce ready for the future? Is it all going to be online? Join us to get answers to all these tough questions. The title of the podcast today is The Future of Research. Can research save the NHS? We know the NHS is continuing to shoulder the burden of COVID and is trying to catch up with the care backlog. Is research a burden or a knight in shining armor? To discuss this topic, I'm joined by Mital, Sofia and Tanya. To start with, could I just ask each of you to introduce yourselves to our listeners?
My name's Dr Mital Shah. I'm an ophthalmology registrar and I currently work at the Oxford Eye Hospital. And over the last few years, I've been involved in the running and delivery of a number of different clinical trials. And my recent interests focus on the use of retinal imaging and artificial intelligence in ophthalmology.
Hi, my name is Sofia Cerdeira. I am a clinical lecturer at the University of Oxford and a doctor at the John Radcliffe Hospital. I looked after pregnant women and I have a particular interest in maternal medicine. And I do research in preeclampsia, which is an hypertensive disorder of pregnancy.
Hi, I'm Dr Tanya Baron. I'm an emergency medicine consultant in Oxford and have previously been a GP. I'm involved in various trials within the emergency research and chair our local patient and public involvement group. My passion is to make research accessible to everybody and to ensure it's a normal part of patient care.
Thank you for joining all 3 of you. I'm going to start with some facts. The last report looking at this from the NHS is from 2018-2019. Supported clinical research activity generated about £2.7 billion of gross value added to the UK economy and estimated 47,500 full-time equivalent jobs. Direct income from the NHS, so this is directly money going into the NHS. Commercial clinical trials and the NHS delivering those generated £355 million of income to the NHS. And the total estimated cost saving was £28.6 million where trial drugs were used instead of standard drugs. Knowing that, can the research save the NHS? Mital?
Yes, I think it can, and it will, and it should. You've kind of highlighted really, really clearly the financial benefit and the impact that research has, not only on the NHS, but on the wider UK economy. And in addition to that, we know that patients who are treated at hospitals that are research active have better outcomes, have reduced mortality, and they also tend to find that if they're admitted to more research active hospitals, that their patients have more confidence in staff and tend to be better informed about their condition and any medications that they may be taking. So I think definitely trying to increase research within the NHS and increase research capacity within the NHS will have both positive financial implications as well as implications or better outcomes for patient care.
Yeah, we may be biased because all of us have a particular interest in research, but I mean, our interest is actually the impact that it can have in the patient's lives, in the patient's outcomes. And, through research, this is how you can evolve and improve care. It's all about the patients and have a patient-centered and patient-centered approach. So, by improving the research and the research training that we give to allied healthcare professionals, that will certainly come back to the NHS improving care to our population, definitely.
The COVID was a burden, is a burden still, but it also showed what can be achieved if we really integrate research into the standard care pathways. The recovery study is a great example. The simple innovation of that was to make the study use existing medications, existing care systems, and randomizing at scale at many hospital centers that normally don't recruit actively for research studies. And that showed that we could deliver new treatments within months of a brand new disease coming into focus. 30% of all patients hospitalized for COVID-19 in the UK were randomized in a huge clinical trial, the recovery trial. So at what cost is that, Tanya? You were there, you were on the front lines, you were holding the charge at the right of the front, you were there. But what cost was that? Did it cost you, your team, anything? What was achieved and lost by making research right there at the front?
I think from our point of view, from within emergency medicine, it was really amazing to see. I think that it just basically so many people coordinated and the collaboration across different departments. Everybody, the patient, the clinician, everybody had a vested interest in these trials. And I think that was the first thing that made a big difference. Everybody wanted to do something to help. Everybody wanted to be involved. And I think seeing that all happening and it happening so quickly, and in fact, I think Oxford was one of the highest recruiters across the whole of the UK for the recovery. And actually, it was really, really great. Our department is research active, but having the resources that we had put into the front line really at that time was probably not seen before. And I think, unfortunately, it's probably something that's not sustainable in the long term because people, obviously, then other research studies were actually neglected to prioritise the COVID studies, and probably rightly so at that time. However, that's not a long-term solution. But it did make a huge difference, and it was really really impressive to see. And it's really interesting speaking to our research nurses who were involved in that actually, and definitely something possibly for another podcast in the future is to hear the stories of how they felt themselves undertaking that research on very sick patients. Yeah, but as I say, on the whole, I think it was a good experience.
Yeah, I think it showed really, really well how when everybody has the same goal and when resources, I suppose, aren't limited, what can be achieved. But as you kind of alluded to, the other side of that, or the cost of that, the pandemic and the research, was lots of other studies being stopped. So, for example, in ophthalmology, essentially everything came to a complete standstill on the research front, and our research nursing staff were redeployed, as were a number of the other doctors, to other specialties. So it's important to remember that one, I think when resource isn't an issue, we can do lots. But now, particularly in a situation where we're coming out of the pandemic and we're faced with big backlogs within the NHS, and potentially what impact that might have on research. And also, I think it's important there to think about actually how can research help us try to come out of that, either through innovative ways of working or looking at new sort of treatments and new approaches that might be useful and helpful on a day-to-day basis.
Definitely think from an ED point of view, the way we, for example, take consent has changed, and that happened very quickly actually, and we have since then pretty much paperless consent, and that's come because the digital platforms were quickly updated, I suppose. But yeah,
we also learned, I think, like Tanya was saying, we learned to use other things well. We learned how data was collected. The data form, if you remember, Tanya, for the recovery study was incredibly simple. You know, it's a website. You went there. There was maybe 8 questions, and it demystified and make it uncomplicated, the whole idea of trials. But by doing that, by just joining a study, we have improved the care of that participant. Even if they were allocated placebo or usual care, we actually improved usual care. In fact, there was a great paper that showed that people in the usual care arm of recovery lived more than if you weren't in any study at all. And yes, there could be some selection bias to that, but I think that in itself is a good reason to perform more research in the NHS. training is something Mital brought up. So how we're going to have to spread out this army that we mobilized to deliver that. But what particular things that we did then, and did those nurses and healthcare professionals and doctors from other areas motivate members of your teams to do more research? How does that link in with the CRN's goal of training more people to be research active? Any experience with that in your
I
side?
think it certainly made other sort of emergency medicine clinicians more aware of research as a thing, whereas before I think it had always been something that people did, but nobody really knew much about it. But I think when COVID struck, and actually we weren't as busy with our other normal patients at the time, it gave people sort of something else to do. They felt that they were not just managing the patient who was unwell, but also able to help or identify patients for trials where they had previously not been involved in research. And I definitely think research is there's more awareness about research within our department since then.
And maybe that's it. NHS is for the greater good, but being part of research gives you a very concrete greater good that you're working towards, and that is in itself a huge boost to our we can say almost exhausted workforce, but it does give that concrete thing to look at. So we all agree research is valuable for the NHS. Why then, and I'm just stirring the pot here, I'm making a controversial point, should consent be opt out? Should everyone who comes to the NHS, which is already working to the greater good, try and do even more for the greater good? What do we gain by making research consent opt-in, especially, yes, I know you'll talk about intervention studies, but especially for observational research, especially for data-driven research? What do we gain by making consent opt-in, or what do we lose by making consent opt-out? Sofia?
I think that if you were using an anonymized, if you're using patient data, patients should be aware and should be able to say, yes, I'm happy for my anonymized data to be used. And I think this is something that would be quite important to set up in a large scale, so that is just routinely collected data that we have sitting on our information systems. And if we can use that data to make some interrogations in order to improve services and departments to do proper research with it, that would be great. If you can create a system where the patients would be informed that this could happen and have the possibility of opting out, opting in, opting out, I think that could make a big difference. That would increase substantially the possibilities.
I think it's always important to make sure we don't forget that ultimately, and for both observational and for interventional research as well, participants have the right and the option, and they're able to sort of withdraw from studies at any point in time. So I think while it's a noble cause to try to improve recruitment to research studies, make everybody, both staff and patients, more research aware, mustn't lose sight of the fact that currently, research is optional. People should be informed prior to taking part in any studies. As part of that informed consent process, they have an option to sort of decide if that's something they want to go ahead with or not.
It was interesting because we actually brought a similar question to our PPI group about whether they would be happy to have some of their sort of old used blood that had been taken already for their medical care stored for future use. And actually there was quite a mixed response, because I, in my naivety, expected that nobody would have any concerns about that. But interestingly, they felt that when they're presenting acutely, they might not be thinking clearly, might be unwell, not able to give their full consent at that time. And also there was anxiety over if they said no, whether they would get the same standard of care. And then it went on to how would you assure people that their bloods had been disposed of at the end of the day, and how would you reassure people who didn't want to be involved that actually the samples wouldn't be used at all. So I wonder if using consent as an opt-out, if it's planned in advance in the same way like we were talking about carrying donor cards and things, whether that might be a useful way, or having a registry, I guess, nowadays, seeing as we're paperless, but having some kind of way that people are not having to make these decisions when they come in unexpectedly.
No, I was going to say, I think it's important to remember that, especially in acute settings. I mean, I'm sure Tanya has more experience of this than I do, but if someone's coming into hospital in an emergency, they're unprepared, or even if they're going in for a procedure, an operation or something, they're nervous, and to sort of be thrust upon at the last moment with all this information to try to absorb that, digest it, and decide, is it something I want to take part in? It may not be the most appropriate time. So I think certainly that's something that, as researchers, you need to be sensitive about, to making sure that you're approaching participants at an appropriate time when they can take this sort of information on board.
And you mentioned the magic word there, time. It takes time, research. In fact, the most generous gift that our research participants give us is their time. And you also said about, if we made it routine, do the participants know that their visits are taking longer because we made it routine that they're part of research? Are we affecting their work? Are we affecting the likelihood of someone coming to your specialist service in Oxford from rural Gloucestershire because they feel like they wouldn't have the time to spend when they come here? How would we solve that? Do we have any suggestions? How would we make sure we are not overburdening participants who don't already know they're doing this extra?
I think here, I mean, information is key. That's sort of similar to what Tanya's experience with her PPI group previously, and their concerns about not knowing what's going to happen with their samples afterwards. In this setting, participants or potential participants may not be aware of exactly what does that involve. And I think in a future where research plays a much more integral role within routine or standard NHS care, everybody will be more informed. That's potential participants, healthcare staff, and actually knowing what might be expected and the kinds of things that might be expected. And I think the unexpected can always be more daunting for everyone. So I think certainly one important thing to overcome to get to that point is getting people more informed about actually what it involves, and what the potential benefits and the risks might be as well. So when they're coming in, it's not the first time they're necessarily having to think about that.
And another example brought to me recently was about, if we're making it routine, we shouldn't underestimate how special that is. How special it is that our patients or participants or members of the public are donating their time and themselves for research. And if we make it routine, we shouldn't get to a point where we take it for granted that people will sign up. Approaching someone, in the emergency department is one thing, but approaching even for planned operations, should it be okay if I have an opinion on this, but should it be okay that if we approach the participant only on the day, when we could have approached them in advance and had the time to think about whether or not they want to join a study, even if it's observational? Is it ethical to leave it to the last minute, something that we could have done earlier? Sofia, for example, if someone's coming in for pregnancy is 9 months, you can plan for something that's going to happen in 9 months' time, most of the time 9 months. Is it okay to ask them to join a study on the day of their labor when they could have done that in advance?
My experience is not working with patients in labor. It's quite difficult. That will be similar to Tanya talking about of patients who come into the emergency ward. But luckily, we have 9 months to prepare. And the pregnancy are patients that we keep in a tight follow-up, and we are able to approach on several different times. So although it's not ideal, but I feel that we are in a better position than the emergency department with Tanya. and we can start giving patients the leaflets, and they have the chance to think about it on the day or come back to us later on in 1 or 2 days, and we can always follow up. The experience that I get is that the pregnant women engage when we asked about research, and they're quite good in terms of participating. At the end of the day, you want to create strategies and opportunities so that research becomes a normal part of clinical practice, and that's what we want, and that's how then we can improve the NHS as well. But actually to create those strategies is what's going to take the time and effort.
I think it's also important to say that using your example previously, Sanjay, of approaching participants who are coming in, or potential participants who are coming in for planned care, be that an operation or a clinic visit, all research still, particularly, well, not only intervention, but some observational studies as well, will need to be or go through the appropriate ethical checks and balances to make sure it's ethically appropriate and sound. And as part of that, I think where you have an opportunity to approach somebody ahead of time rather than in the heat of the moment, I think the onus definitely is on the research team to try to do that where possible, so that a potential participant has as much time and space to think about it and to talk to other people or healthcare practitioners at their leisure.
Yeah, no, and I think you focused, and there's an important thing you mentioned, Mital. I mean, it may not be obvious for people who might be listening to this podcast, but every single research study, from the most simple one, observational, to the most complicated interventional study, goes through a process of checks and ethics teams, and is very scrutinized as to make sure that this happen. But what we're talking here about is the opportunity to make it more common and be embedded in normal clinical practice, and be actually a part of just regular encounter with the patient and thinking about research. And I think this is what we need to try to make it happen, make it more normal, more regular, and part of normal clinical care. And how can we do that? And this is how we go into opt-in, opt-out, the use of regularly collected data. And I think there's a lot to be gained with that.
I was just going to say, actually, nobody ever likes talking about money, and I know you mentioned at the start about the money that's brought into the NHS from doing trials. Do participants or our public and patient members, are they aware of the money that comes into the NHS by them taking part in trials?
That's a great point. We tell our patients in ethics committee, ethics documents and patient information leaflets if we are paying them directly. So if you join a complicated study, some studies will pay the participant, and we tell them that. But maybe it should be okay to tell the information sheet to the participant, this is how you're benefiting not just you and the medical problem that we're solving, but also the NHS overall. I think it's okay. I think it should be mentioned. In fact, that's useful information when you're considering how your time is valued. That's a great point. Taking it back to you, Tanya, we talked about the challenge. Yes, the onus is on the research team to do as much as possible, as if we have the time to give the information. But you are a successful researcher, multiple studies, lots of very acute research work. I think you're the second highest recruiter for some studies in the country. So how do you do it? How do you work around that in this area where everybody who comes to the hospital has to come to the emergency department, right? Or almost everyone, unplanned care, all comes through you. How do you deal with that problem, and how do you make it routine in your care?
I think it is a very challenging environment to do research within the emergency department, and I think the reason it's successful is because we have such an amazing team of research nurses. If it wasn't for them, it would be impossible to do studies within the department. I think practical terms, we can't do two things at once. I can't be clinical because the departments are just so busy, and also research or recruit patients to research. And so the most I think we can hope for while we're actually on shift is to sort of raise awareness amongst other people who are working, and to sort of flag up any patients really who could potentially be recruited to our research nursing team. And I think one of the challenges from a nursing point of view, and I'm sure this is similar across the UK in emergency medicine, is that our sort of peak presentations are out of hours really, so evenings and weekends, and that in itself poses problems. And so actually what we do is we're looking at expanding our research nurse numbers to cover later. They already cover quite a lot of hours during the week and are now extending to cover weekends, or some weekends as well, but also to look at using sort of other people, so thinking outside of the box. So one of the reasons some of the COVID trials were so successful was because we used a lot of medical students. So we had medical students seconded to us in ED during the pandemic as extra pairs of hands really, and they got involved in research and recruited for us, and that's a sort of plan to look at how, if they can be involved for more sort of other projects and things too. And also whether we look at using our clinical support workers as well, to start recruiting out of hours, because the intensity of the work is just, as I say, too much when you're actually on shift, but actually the out of hours work is the where all the patients are coming in really, and we want to make sure we can recruit them as well.
Any final thoughts from you, Sofia?
No, I think we touched upon very important points, and Tanya just highlighted this important point of having other people involved.
You still think the research can save the NHS, Mital, after our conversation?
Yeah, absolutely, yes. Despite my personal bias based on my sort of interest in research, I still generally think that research can save the NHS. We've heard that it improves outcomes. We've heard that the positive financial impact it has both on the NHS and on the wider UK economy. And I think one of the themes that we've talked about is we need to slowly try to engage a cultural shift to try to make it a more routine part of NHS care. And that's going to be both patients knowing more about research, what research might entail. So when they're approached, it's less of an unknown. And also making sure that there's appropriate support for healthcare staff in terms of training, so that they're in a better place to be able to help deliver research studies going forward. On that note, to all our listeners and healthcare professionals or members of the public, if you have any thoughts on research, if you want to learn more for healthcare professionals, please look into what training is available for you, freely provided from your local clinical research networks in your area. Please think about what else we can do to make research a routine part of NHS care. Thank you, Sofia, Mital, and Tanya, for joining me today in this podcast. And thank you to all our listeners for listening to this podcast series. Thank you. Thank you for listening to this special podcast series from the NIHR. If you are a member of the public interested in research, please visit the Be Part of Research website to search for studies near you that you can take part in. For health workers who want to find out more, please visit the NIHR Your Path in Research website to get started. If you have specific research training and research career-related questions, please speak to your local friendly NIHR Clinical Research Network.